well-being in society, from hunger to access to service, service delivery, and general feedback on how people are experiencing life in the province. The data is there. But is the data feeding in and informing the way that policy is being crafted? And I would argue that it's not. Policy kind of happens at a political kind of ideological level, but is often very delinked from what the data is telling us. And if you look at the hunger issues, for example, hunger is by and large an urban problem. This is something people don't reflect on often. To say, if you want to resolve hunger, you have to go to where people are and to where people are hungry. And you have to be able to understand systemically what are the other elements that you can address to enable that for people. So the cost of transport is a big one. You can't say you want to improve somebody's cost of living or quality of life without engaging with the cost of transport, without engaging with the amount they're paying for housing, and then understanding what then do they remain with at the end of the month to be able to afford food. And so my point is, I think policy absolutely is catalytic. It can deliver wide-scale change. Hence why I made my own personal choice to leave private sector, to leave the civil society space and come into politics, because I believe that this is where real social transformative change can happen if the right people are in the room, but also if the solutions are evidence-based.
So you've already supported 10,000 producers, township abattoirs. So you are doing that, and you've only been in the role less than a year.
Well, we've been busy.
You've been busy.
But to be fair, and I'm coming back to your earlier point, the what you measure matters. And often, I actually think the flaw in the system is that what is measured are the inputs. So we pat ourselves on the back and we say, we supported 10,000 smallholder farmers. Great. What happened to them a year later? Where are they 5 years later? How much market share are they growing in the specific commodities that they're trading in? Are these businesses sustainable? Are they becoming clients of the bank as business banking clients? Are they taking out loans? So we're not looking at the output to say that which we put in. It's great that we supported 10,000 farmers, but what does that mean for us, and does it actually shift the needle in the long run? And I think we do have to have a conversation about what we measure and review and have a lot more impact assessment being filtered into the work of government.
So everybody's listening very, very quietly. Shall we give them an opportunity maybe to ask one or two questions? Let's do that. Is there anyone in the room that is brave enough to ask our distinguished guests a question? I think that we have roaming mics. I'll look around and see. I don't know, I think we need the first coffees.
Still early.
It is still early, I know. No questions at this point in time? Okay, well then you'll just give me more chance to ask questions. So Peter, beyond CSI, and as I've said, we can do less harm and we can do some good, but not necessarily enabling most good. So beyond CSI, what could Life Healthcare, and maybe even more generally the SA private healthcare sector, do to create those green swan moments, to enable most good, not just to do the little good you can with the CSI money that you have on the side of your desk? What does that look like? Now, unfortunately, we don't have Dr. Makhana here. I would have wanted you to tell her straight to her face what potentially Life Healthcare and Better could do if you're not already doing things in the public-private, academic, civic partnership space. But what would you say?
I think CSI under the guise of a charity banner is not sustainable. To my mind, it's when people tick boxes, they've done what they need to do, hopefully no one asks any more questions, we've ticked the CSI box, let's move into next year and then do it again and hopefully not annoy any shareholders who question your judgment. Real CSR, from our perspective, is one that is programs that become self-sustaining. And I think in healthcare, the largest contribution that we can make actually is money to some extent, but to a large portion is systemic and intellectual. And to the point of making systems and processes better, I think it comes through collaboration. If you listen to fireside chats, depending on who you listen to, is the private sector can learn from the public sector, the public sector can learn from the private sector. The interesting part for me is both aspects of the healthcare delivery system can learn from one another. Yeah. We face different challenges at different proportions and scales on a daily basis. And interestingly enough, by seeing the solutions that the other parties already implemented, we can actually improve all of our systems together. So in part, it's about how we create programs that encourage this integration between the two aspects of a very complex system, so that by learning from one another and appreciating the excellence that sits in both pockets of delivery, that if we just copy the excellence that sits in the other sector, we can make the systems better. So at a very high level, we need to make sure on two fronts. One, our CSR initiatives are largely centered around those aspects of the environment that we've got to take responsibility for, primarily in water and medical waste, which hospital systems generate, and in so doing, need to make sure that we are typically taking care of our own challenges. And then to the extent that we can harness the resources, like we did with Nelson Mandela's Children's Hospital and Operation Smile, private sector resources, the capacity that sits in the public sector, together with patients crying out for cleft palate operations, it's an aspect of showing bringing these together delivers a solution. How we make it more sustainable on an ongoing basis, that is where our challenge lies.
I hear you. I'm going to ask you now, because you're the politician, and so therefore, you always have the final word. Yeah. You've said that we can end hunger in our lifetime. Now, if you had one call of action for everyone here of how health, agriculture work together, what would be that one call to action that you would leave everyone with?
Well, that's a good question, but I would say before we have health practitioners, we actually have citizens. We have residents, people who live in this city or live in this country. And I would say that we need to really rethink and reframe our thinking about food and food production. And it actually needs all of us to have a bit of a shift in how we think about it. So whether it's, this is what I touched on when I spoke about the schools program and the clinics program, whether it's a clinic, whether it's an open space in a community, whether it's your backyard, your back garden, I'm saying we actually need to turn every patch of available growing medium into an opportunity for food production. And we need to integrate food production and thinking about the food system into our strategic thinking, even as health practitioners. Because as I said, health is the output, but food is the input. So we've got to work closer together. I've started having discussions, and it's unfortunate she wasn't here, with the CEO of Baragwanath Hospital about they've offered to allocate us some space at Baragwanath Hospital to set up community gardens and food gardens so that they can also be able to produce some food themselves as well as create a space for their patients. And I'm saying, let's work closer together and have an end-to-end approach and turn every available growing medium into a space for food production, because we really do have a lot of work to do in that regard, and there's so many people in this room that can play a part in that.
Fantastic. In fact, both of you have said exactly the same thing, and that is that we have to have both a cultural change, we have to have a systemic view, and that we have to enable, optimize, and make the best of public, private, academic, and civic partnerships, because this is not the kind of thing, regeneration, dignity is not something that you do on your own. Was there a question from you, Melanie?
Thank you. Appreciate it. So, MEC, I'm going to start with you, and maybe I could just table the question and let you process it. But firstly, congratulations on the new united political party that's being formed, and might be a good opportunity for a little plug while you're at it. But you have historically spoken about good policy in a three-legged table, and you have briefly touched on it in a few elements, but maybe we could come back to that and see if you want to connect those dots a little bit better, because I thought it landed quite nicely from a health policy perspective too. So I'll leave you with that, and then I want to toggle over to Peter and Rose. But Peter, you eloquently spoke about the very real reality about capital is scarce. We've got to meet our returns on capital. There's no doubt. It's not really sustainable if we do this from a CSR perspective. But if we look around the world, there are a lot of health systems where the public sector, even if it is a national purchaser, does procure, universal health type system does procure from the private sector. But in order to do that, it does require some levels of cross-subsidy in the health system. Now, in the audience here, we have a lot of medical schemes. And what this requires, though, is differentiated pricing between private and public. So we need two things in order to enable the government purchasing from the private system. One is we need the generative reality where you do have some returns above the cost of capital that allow you to cross-subsidize. And two, you need to have that mentality in the private contracting system that caters for differentiated pricing between the private and the public. I would just love you to expand on that. I would appreciate your thoughts on that. Thank you.
Peter, you're going to need a little bit of time just to absorb that question. Three-legged stool.
Yeah, so, and I like that framing, actually, of the three-legged stool. It really is, for me, about policy, leadership, and impact assessment as the three key things that drive the outcomes that we're looking for. And policy, even when we develop new policy, it's not about creating new rules. It's actually about thinking through creating new incentives, new mindsets, new systems and ways of thinking about things. And I think agriculture and healthcare actually might have similar challenges in that, and I'm not a healthcare expert by any stretch of the imagination, but we have a challenge of fragmented systems and legacy kind of inequalities that we're trying to resolve with a heavy-handed kind of policy stick approach. But actually we need to be looking at it holistically and saying, all right, you put the policy in place, you've got the people in place, obviously it has to be evidence-based, and you need to be able to be in a constant state of impact assessment and iteration, because that's another thing. It cannot be static. You have to be able to periodically review and say, all right, did that work, didn't it work, how can we do it better? And I think that is where we then start to develop policy that starts to actually be more meaningful and impactful, and people can actually see and feel and touch it. And if it doesn't work, we must throw it out. We have a tendency of sticking with things just because we said it's a policy. Policy is a big word. A policy is a nice way of saying we're giving this thing a bash for a few years. If it doesn't work, we'll try another policy.
Thank you. Peter.
MEC, you've given me lots to think about today, and I thank you for the intellect that you brought to the conversation. Melanie, to answer your question, I think in any efficient system, there have to be guardrails, let's call it policy, but there have to be mechanisms that drive efficient outcomes. Typically in normal buyer-seller arrangements, if quality stays the same and you reduce your price, volume goes up. But intriguingly, in the healthcare system in South Africa, the purchaser, the payer, and the recipient of the service don't actually work in a triangle that gets to a normal outcome. It has to be artificially created, negotiated, and agreed. In the context between the public and the private healthcare systems, the one asset that I think is underutilized, and I say with confidence, is the private sector has more capacity to process or accommodate patients in the system than are currently moving through the private hospitals. The privately insured market is not growing, so where are we going to get the volume into the spare capacity that sits in the private sector? Question. If private sector just reduces its prices, all that happens is the same 9 million insured patients just move between the different private hospital groups. The reality is that we have underserved aspects of South African society in the public sector who are not getting the level of healthcare service in the public sector, which could be accommodated in the private sector. So to my mind, to draw these two together, we can reduce our pricing, provided we take responsibility for not wasting and being efficient. In the context of being the lowest cost operator in the system, public and private, it would be in the government's interest to send public patients into the private sector because we can deliver the service cheaper than is currently available in the public sector itself. And I think therein lies the opportunity for us, that if on a trusted basis, the public sector could recognize that the spare capacity inside the private sector, appropriately paid for, is still cheaper than what they can deliver, and in the best interest of society to make available, I think this wheel starts to spin much, much quicker. So we move away from an ideological difference that there's no role for private sector. We move into your space where government does buy services from the private sector, but it buys it at a price that is cheaper than they could deliver it themselves. And think therein lies benefits to society, to the public sector, to the private sector, and then you'll find capital coming back into the system, more investment, and so this thing constantly then reinforces itself. It just takes one brave step.
Thank you. Thank you for that, Melanie. Thank you for your question, and thank you for the responses. I did say that you have the last word. I was lying. I have the last word.
Thank you. That was
Colleagues,
very interesting.
Human dignity is not a luxury in healthcare. It is a precondition for its sustainability. And I hope that what you have witnessed here through these stories are not just a set of projects or organizational experiments. Listening to, I hope, and what you've been hearing, I hope, is a different kind of story. It's a story about home, a story about possibility. It's about what happens when we choose ecosystems over egosystems, when we choose regeneration over extraction, when we choose agency over paralysis, or even worse, indifference. You've heard from these two colleagues who have not just shown up, they have leaned in. They have made situations happen where they balance responsible capital management with fairness and care. And they have taken values into policy, feeding the nation, healing the land, empowering people, educating people, our young people, and at the same time, also employing people. All in the interest, in the language, and in the practices of Ubuntu. I hope you read the white paper, but even if you don't, I hope that you do get to appreciate, like I have done, what Margaret Mead has said. She was a social anthropologist. Many, many years ago, she said, never doubt that a small group of thoughtful, committed citizens can change the world. In fact, it is the only thing that ever has. Because, colleagues, it's not going to be our data or our policy or even our profits that sustain us. It's going to be our collective human agency. Because agency is what converts care into action. It is what transforms good intentions into better systems. And it is what keeps the hope alive, even when the headlines don't. Over the next 2 days, you'll hear many, many more stories. I want you to not see those stories as mere metaphors. Those stories are blueprints of what sustainable healthcare really can be. Those are stories that are going to teach you that community is not a place. Community is a promise of value. Community, whether that is a community of stakeholders, whether that is farmers, whether it's a community of stakeholders that involves clinicians, whether it's a community of stakeholders that involve funders, hospital providers, medical device providers, regulators, those communities don't just have value. That community is value. You are going to go back to your ward rounds, you're going to go back to your management meetings, back to your investment decisions, the decisions you get to make, going to go back to your ESG dashboards and your marketing strategies. But before you do, I want to leave you just one last story. I have many of them. And it's a story told by Edward Chamberlain. And he was telling the story about an elder gentleman in a village that was asked to show that he owned the land. He didn't bring a title deed, he didn't bring his ID document, he only simply told a story in his own language, in his own words, not to convince anyone, not to condemn anyone, but really to help remind them. And in that moment, even though half the people couldn't understand the words he said, they understood one thing, and that was that he belonged there. And so I leave you with this. If this is our land, then where are our stories? Not to convince, not to condemn, but to remind us that this place is ours. But probably more importantly, if this is our land, and surely it is, then what are our stories? And who gets to belong in them? You can decide. Thank you very, very much for this opportunity to share this morning with you. Thank you to my panelists.
Thank you so very much to Rose, to Peter, to our MEC for the wisdom, the insights, the clarity shared from the stage. I don't know if it's just me, but one of the things that stands out the most, the image I won't forget, is our MEC at 65 in a bikini. I mean, I couldn't get away from that. Why don't you give our panelists and Rose a big round of applause. Thank you so much, guys. It's interesting, you talked about Henry Ford, and you can have any color you want as long as it's black. There's a very real reason why he said so. In between 1907 and 1927, the Model Ford T Company, or the Ford Company, produced 15 million Model T Fords. By 1913, with the application of Henry Ford's moving assembly line, the chassis assembly went from 12 hours down to 90 minutes. And by the time the last Model T Ford had moved off the assembly line, they were producing them at 24 seconds. And the reason it had to be black was black paint dried faster than any other paint by 3 seconds. That's why you can have any color you want as long as it's black. It was all about efficiency when it came to Henry Ford, as Rose pointed out. By the way, if you had a good weekend and you enjoyed your Saturday and your Sunday, you can thank Henry Ford for that too. Not sure if you're aware of this, but in the 1920s, the average working week in America was 6 days a week, 10 to 12 hours a day. Henry Ford shocked the world when he took his factories and he said, we are going to a 5-day week, 8 hours a day. And he did that because he felt his workers needed rest, and they produced far better turnouts and outputs when they were rested and relieved. And so thank you, Henry Ford, for our weekend. I think, Peter, in your words, he went, profit and healthcare don't go hand in hand. That was Henry Ford's way of saying just that. I loved what IMC also said about food is the input, health is the output. You've heard the phrase, you are what you eat. We're healthcare practitioners. We know that's complete myth. That is not true at all. You are what your body does with what you eat. You know that. 2 people eat the same slice of chocolate cake. One burns it off like jet fuel. The other stores it like retirement savings. Different context, guys, different hormones, different genetics, different everything. You are what your body does with what you eat. Lots to share, lots to post. If you are wanting to post, there is open Wi-Fi. Southern Sun Conference is the Wi-Fi you want to get onto. Just click the box that says agree to terms and conditions, but like the DA did a year ago. And you can have free Wi-Fi for the rest of the conference, which is really, really great. There's also a lovely conference gift on the table, I was going to say grinder, I think it's a grater, that's probably the more accurate term. Lovely work of art, a ceramic work of art from Chris Mahanga, a local artisan who originally came from Zimbabwe, was a medico-social worker working in a hospital in Zimbabwe, came to South Africa and had to pivot and now employs a number of artists doing some amazing ceramic work, so do enjoy that. A lovely upgrade gift from last year. Dis soos trappe van vergelyking, onthou julle dit? Goed, beter, beste, en mooi, en mooier, en mooiste, en mal, en maller, en malema, which is amazing, man. Guilty. 15 years minimum in prison for illegal possession of a semi-automatic weapon. That's going to be an interesting play out of that. I mean, that said, we face the illegal possession of semi-automatic weapons all over Johannesburg most days. We call them taxis. I think many of us have had heart-stopping moments with taxis in our lifetime. Imagine what their hearts are doing as taxi drivers. And I ask you that question because that's almost the topic of our next session, a fascinating pairing of science and storytelling. Dr. David Yankelo and Mandy Fine are here to show us that AI can change behavior even in taxi drivers. So let's see what they're doing when data meets daring. This is David, this is Mandy. Let's give them a round of applause.